Hi guys, good evening. Myself Dr. Kunal. I'm here for your Pathology Fmge recall 2023, which happened yesterday on 30th of July. Now, regarding the paper, we are having a mixed reviews. People said that it is moderate to tough kind of a paper, in which paper number one was a little tricky and paper number two was little doable. Now, whenever you come out of a paper, this is, any exam is an exam, and we get that it gives us a little panicky kind of a situation. Sometimes something will come difficult, and sometimes something will come difficult. Now, for paper number one, last time on 20th of January, paper number one was very easy, single liner, so people were very happy when they came out in the break. And second paper was a little tough, and the moods were down, and people were saying it's what came, we don't know, but results speak for themselves, and we had one of the best results in the history of FMG exam, and we hope and we pray for all of you that this time also it remains the same. Yes, we know, we are with you. We know that the questions which came this time were a little different from what we were expecting. Even the clinical cases were there, three, four lines of questions were there. But as they say, if a question is single liner, then it is yes or no for you. Either you know it or you don't. But if a question is three, four liners, then if you have known the topic, then you can find out those keywords from there, and then you can at least comment on what can be the answer for this question. So before starting with this recall, I would like to thank the students who have helped me in making it. Uh, I can totally understand what you went through in the exam, because when we were interacting with the students, we are not able to form the entire question. So what I did in this recall, I didn't add anything which has not been told. I mean, I didn't try to frame the question. What I've done is I've tried to put the essence of that question, and whatever options were given to me, I wrote that. And my whole agenda is to give you that what came, and if this was it, then this was the answer from it. Because the clinical scenarios can be thousands. So we cannot create it entirely, it won't be created it, and you only know what came. We can't comment on that. Okay, so let's start quickly. The first question: what are the features of irreversible injury except? So we are talking about the cell death. What would you see in cell death and what not? So pycnotic nucleus, apoptosis, yes, you would see. Bleb formation, no, it can be seen with reversible injury as well. Karyolysis, again a very characteristic feature with necrosis. Densities in mitochondria, I mean most characteristic feature of any kind of cell death would be amorphous flocculent densities in the mitochondria. So the answer which we come from this would be your Bleb formation. Then features consistent with sarcoidosis were given in the like skin, lungs involvement, lymph node involvement. What would we see? Now again, this has been told to me that this question was a clinical question in which they were explaining the disease, and they even mentioned it as sarcoidosis, and they were asking about what kind of granuloma would be seen. So we have read it multiple times in the chapter of inflammation that whenever we are talking about sarcoidosis, there's non-caseating granuloma. So caseating granuloma is seen with TB, eosinophilic granuloma is seen with Churg-Strauss, and stellate granuloma is seen with LGB. So options could be up and down, but sarcoidosis question, they asked the granuloma. This is the essence of this question. Now, one more question came in which they again asked for a granuloma, but this time they mentioned it as a TB. So again, it was a clinical case related to TB, and they were asking what kind of granuloma. And somebody said, even they have mentioned that it was Zedden stain positive or something like that. So again, it is caseating granuloma if it was TB. Most common cancer of thyroid, again a clinical case was there, and they said the age mentioned was 20 to 40 years. They were not able to put up the features what was asked, but again the essence was most common tumor of thyroid has been asked, and it is, we know that it is papillary tumor thyroid. Then the fifth question, again this is ferroptosin. It is inhibited by. Now, this question, there were two questions actually with the same options I have been told. One was ferroportin. Now, when we are talking about ferroportin, this is a molecule which will take the iron from the storage site into the blood, so or make it available for erythropoiesis in the bone marrow. So we know that who blocks it? The Thor hammer, hepcidin. And who is secreting the hepcidin? Hepcidin is being secreted by liver. In which disease we have read it? This is the pathogenesis of anemia of chronic disease. And we discussed the main pathogenesis of anemia of chronic disease was the secretion of interleukin 6. So, the answer for this is interleukin 6. It is inhibited by hepcidin, which is formed because of interleukin 6 secreted, which is in turn stimulating the liver. Then this was a question, chronic inflammatory mediator they asked. Now again, for a chronic inflammatory disease, interleukin 1 can't be the answer. The correct answer is interleukin 6. Now people, they mark TGF beta also in that because of fibrosis it gives. And yes, repair is a very good part of chronic inflammation, but then they're asking the main mediator for a chronic inflammatory disease. So it is interleukin 6, okay. Then again, a clinical case was given in which, a drug allergy was told, and after 2 days, hemolysis was seen, the antibodies were killing the RBCs, and people got confused with the drug allergy and marked type 1. But we have discussed multiple times in the classes, if they are talking about anything related to blood, I've told you, you have to go with type 2 hypersensitivity. They're saying, we have an RBC and this RBC is getting killed by the antibody, right? So this immune hemolytic anemia they are trying to say, and it's type 2 hypersensitivity. Even the mnemonic of type 2 hypersensitivity has got blood in it. My blood group is Rh positive. So the answer is going to be this. Then patient suffering from leprosy, again a case of leprosy was there, and they were mentioned that a numbness on the skin, muscle problems, loss of any kind of sensations was there, pain bhi pata nahi chal raha tha, there was skin involvement was there, and they said that it shows granuloma. So leprosy and granuloma. Now here actually, if they would have not given you even a leprosy case, but they have given you only granuloma. So wherever you are seeing a granuloma, that means you are doing the macrophage activation, right? And it is due to Th1 cells. And Th1 cells are against a chronic antigen, and like it's a helper T cell which is involved in any hypersensitivity which is happening due to a T cell involvement. It's a delayed kind of hypersensitivity. We have type 4. Granuloma hamesha type 4 mein hi aata hai. And it is leprosy ka case tha, but they have mentioned granuloma, so it is type 4, okay. Then amyloid associated with hemodialysis. Again, please do not think the question was a single liner. Again, they were saying a kidney failure case was given, and all the the kidney biochemical analysis was given, that the serum creat and BUN and all that, and they said everything was deranged. And they said that patient has to be taken on hemodialysis, then only what is the amyloid deposit. So I have tried to give you the essence, not the clinical case here, and the answer was A beta 2. Now AL is seen with multiple myeloma, PR was seen with prions, and A is chronic inflammatory like secondary amyloidosis mein A dikhta hai beta. Then thyroid tumor with calcitonin positive. Now again, some people said parafollicular cell was mentioned. Some people were saying some other tumor marker also was mentioned, but it was unanimous that calcitonin was given, and they were asking which thyroid tumor has calcitonin positivity. So we all know medullary thyroid cancer has got a calcitonin positivity. So this is the essence what I'm trying to see here. Even the the language of the options might be a little different, but I hope that with these questions you could relate that, yeah, this was asked. It was a little tricky in the sense what they have written, but this was asked. Then clinical scenario related to Klinefelter's. Again, a long case was there. People said that even the, genotype 47XXY was mentioned, and, other things they have mentioned, and they said that what could be seen with Klinefelter's and what not, except question tha beta. All are seen except. So Klinefelter's, it is 47XXY, so they are males, but, Klinefelter syndrome, it is the most common cause of secondary male characteristics loss. So hypogonadism ho jata beta. So obviously atrophied testes will be seen. These males are very tall. Even the another counterpart of Klinefelter, which is seen in female, that is your 45XO monosomy, there the stature is short. Even minor breast development can be seen. Gynecomastia is a finding with Klinefelter syndrome, but amenorrhea, it's a female problem. 47XXY, these are male Klinefelters, so ये तो दिखेगा नहीं. So except में amenorrhea, ठीक है. Clinical scenario again showing a baby with mental retardation, congenital heart defect, genetic abnormality. Some people said this was mentioned. Some people said it was not mentioned. So, I don't know, but if it was mentioned 47XY plus 21, so it is trisomy 21. And trisomy 21, we know it's Down syndrome. People said that, we were getting confused by the question which was given. But as soon as we saw this image and there was a semen crease in it, we know it is Down syndrome. So 47XY plus 21, it's Down syndrome only. And semen crease, again, it's a very important feature for a Down syndrome patient. So Down syndrome is the answer for this question. Then disease getting transmitted from grandmother to mother, and chances of disease getting transferred to the next generation. So, when there is no skipping of generation between two generations you are seeing, so it could be a dominant disorder, and they're asking the chances of disease getting transferred to the next generation. So basically, I cannot comment over that whether it's an autosomal or X-linked because just grandmother to mother. So मैं नहीं बोल सकता हूँ कि autosomal है कि X-linked है. So इसको हम autosomal dominant लेके चलेंगे, ठीक है? तो it's a dominant thing and autosomal dominant है ये और disease transmission के लिए ये पूछ रहे हैं. So मान लो कि this was the diseased mother and bestest scenario में you are marrying this diseased mother to a normal male, ठीक है? अब आप देखो क्या बनेगा ये. This is this. And we all know that any kind of autosomal dominant disorders, they manifest themselves in heterozygous conditions. So even one mutated is enough to cause a disease. So ये हो गया बेटा और ये दोनों कौन हो गए? So 50% क्या है? 50% are absolutely normal and 50% are having a disease. So what is the disease percentage now? 50%. So answer is 50%. Then again a question came, both parents suffering from beta thalassemia trait. मतलब problem एक chain में है. There is only problem in the one chain in both the parents. अब ये क्या पूछ रहे हैं? Chances of child having a disease. So disease की बात कर रहे हैं बेटा, ठीक है? देखो अभी समझाता हूँ क्या बोल रहा हूँ. This is both the chains defected. Now this is diseased. Okay. Now here when I'm talking about this is again trait ही हो गया ना यार. Single chain defect है ना, both chain defect नहीं है. So इसमें क्या होगा? ये भी सेम हो गया. एक chain defect है, not both chains are defective. और ये तो absolutely normal है. So they're asking child being diseased. So disease के लिए बेटा 25% would be the answer for this. Okay. Then the next question, pattern of inheritance of following pedigree. My God, I got so many different pedigrees from different students. It's, sir, this came, this came, this came, this came. So I'm not pretty sure. But what I was sure about that, majority of people said that it was a recessive pedigree because the students with whom I interacted, they were adamant that from the first generation when, they saw the next generation, the children of these two, they say that there was no disease seen. So when you see no disease going into the next generation, so it cannot be dominant now. Okay, so beta option number B and D to cut gaya. It has to be recessive. So this is recessive. And now I have to talk about the autosomal and X-linked. So uske liye easy rehta hai, take a diseased father. If the father is giving the disease to son, it can't be X-linked because father never gives his X to son. तो बेटा इसमें आप देखो यहाँ तो फादर है, नो डिजीज केम फर्दर. नाउ यहाँ पे कौन है? मम्मी है. मम्मी कैन गिव टू बोथ एक्चुअली इन X-linked बिकॉज मम्मी गिव्स 1x टू डॉटर 1x टू द सन. बट यहाँ पे फादर इज डिजीज्ड, father is diseased here and he has given to a male also. So it can't be X-linked. So what is the answer here? Autosomal recessive. If you're sure about something else, I mean, if you're sure that this pedigree was not there or some other pedigree came or it was some extension in this, so there could be chances, right? So because you were, sitting in the exam and we were not sitting in the exam, it is not about us telling you that, we taught and it came. It was you said that this came and we are trying to just show you that the question might be formed in a different way, but this was the essence which has been asked. If there is any changes you think there were, please mention in the comment below. They'll be highly obliged and it will help us in guiding further students even better. Now, adult with fatigue, pallor, routine blood investigation shows low RBC count, low hemoglobin, MCV was also low, MCH is also low. So, some student also told me that there were microcytic hypochromic RBCs written. So, whenever microcytic hypochromic RBCs are written and there is no other thing added to it, like this is the mnemonic which we have done, and in this mnemonic, this IE is IDA. All this, sideroblastic, thalassemia trait, anemia of Crohn's disease, lead poisoning, they all have microcytic hypochromic anemias. But then IDA, if nothing else is mentioned, because I cannot relate to anything else in this, I have to pick a vague thing. So if I have to pick a vague thing from this, Cetal, I would pick I. Why I would pick I? Because the most common anemia, which is microcytic hypochromic, it's iron deficiency anemia in developing countries. So the answer for this question is IDA only. Okay. Then they said that a 50-year-old osteolytic lesions, normal albumin but high globulin, high number of plasma cells. Some people said even crab was mentioned over there. One feature from crab was also there. So, once we have this kind of a picture, osteolytic lesions, high M spike, high globulin, then plasma cells were there, too many, and then something from the crab. So it is multiple myeloma. It's a plasma cell disorder. Most common plasma cell cancer is multiple myeloma. And they said, what is the diagnosis? So, again, cannot go anywhere else. And people said this Hodgkin's was mentioned, non-Hodgkin's was mentioned. So these were the options which are given to me by the lovely students I interacted with. If you have any other option for that, please. Primary effusion lymphoma. Now this is something which we have done with the vascular tumors when we were reading, the most common vascular tumor associated with AIDS is Kaposi sarcoma. The causative organism is HHV8. And I told you that if, they are the most common overall cancer with the AIDS, again, it's primary CNS lymphoma or effusion lymphoma, and the causative organism for that is HHV8, the same. Then the next question, male child easy bruisability, APTT, PT, INR, everything is normal. What can be the cause? Now the scene is that if देखो, whenever we say male child, easy bruisability, so we think, it's something maybe gender specific. But when we are talking about a gender specific here, then, this question I could not, like relate to. This was a question in which I need your inputs, that what exactly, because people said these were the options and this was the question. Now in this we cannot rule out, because if APTT, PT and INR all were normal, so that means it's not a coagulation factor deficiency. So hemophilia to ho nahi sakta beta ye, because in hemophilia factor, either factor 8, factor 9, factor 11 is involved. But people said von Willebrand disease was given. Now, if a von Willebrand disease is also there, then von Willebrand disease also have a role to play with factor 8 activation. So, if there is a von Willebrand factor deficiency, then again, the APTT will never come normal. So, please give me the inputs over this question. That what exactly was there? Either the question was some changes in this or maybe some changes in this. Okay, so please let me know. Then clinical scenario regarding rheumatic carditis. This was a question in which they were mentioned about the rheumatic carditis. Valvular involvement was also there. And they said that all of the following is not associated except what are the findings you would find in the patient of rheumatic carditis. Now this question came from, what is the criteria? The criteria for rheumatic carditis is Jones, the revised Jones criteria. And in that revised Jones criteria, we have Jones and Peace, the mnemonic which we gave you, when we were talking about the cardiovascular system in pathology. With rheumatic carditis, we have done this. And in that, I told you that, erythema marginalis, Roth spot, Osler's node, staph infection, these all are findings of infective endocarditis in which the Duke's criteria is used. And even, some people said even the Duke's criteria came in the exam with the infective endocarditis, but I think they asked about the organism which is causing it probably. So it comes in microbiology, but for rheumatic carditis also people said that revised Jones criteria came and they said what will be found, and erythema marginatum was the answer for this. Then clinical scenario, again, it was a clinical scenario 3-4 line question in which, there was a purpura on the skin, there was renal impairment, there was hemoptysis, there were respiratory infection, a lot of things were given and people said CNCA positivity was also there. Now we have discussed multiple times, whenever CNCA comes, a very good disease in which there is a triad which is there, skin involvement, lung involvement, kidney involvement. So it could be none other than vaginous. Good pastures may be, you can have kidney and lungs involvement, but then the point is that good pastures में बेटा CN का positivity नहीं आएगी, है ना, good pastures के अंदर. So the correct answer for this is vaginous. MPA के अंदर again it would have PN का positivity. Chuck-Strauss तो eosinophilic granuloma है. Now patient with HbSAg positive, IgM anti-HbC positive. So बेटा surface antigen positive है, core antibody IgM type positive है. People said that the question was exactly these two markers were given and patient was in the hospital for some other disease. Some other illness was mentioned and they said the viral markers were done when you were investigating the patient and the patient found out to be suffering from this. So because IgM is mentioned, HbSAg positive is there, so that means hepatitis B is there. But if they have mentioned IgM core antibody, that means it's in the acute phase. So beta ye acute hepatitis B. Then this image came. It was an image of nutmeg liver. So red white areas you are seeing, red area is a necrotic area, white is a viable area. So patient with ascites, edema, LFT totally deranged, cross from liver of this, what is the likeliest cause? Now whenever this is actually a nutmeg liver. So when I'm saying it's a nutmeg liver में बेटा sinusoidal dilatations and periportal fibrosis हो जाती है, red white areas मिलते हैं, वही है ये. And the thing is, they're asking what is the likeliest cause. Now, in this again, there were some confusions that whether what was it? The question was framed in a different way, please let me know the options for this question. As far as things what I have discussed with the students, this is a case of chronic venous congestion. So whenever we are not able to the blood is not able to get away from the liver and it's getting collected, there's a blockage, drainage nahi ho pa raha hai. So chronic venous congestion would be there, and because of which nutmeg liver can be seen, and these patients they go into right side heart failure. So ये problem होता है, because of which there's a backflow of the blood. So chronic venous congestion, cardiac cirrhosis बोलते हैं इसीलिए इसको. So chronic venous congestion would be the answer from my side. If there are other options, if there is something else you can add it, please do in the comment section. Patient present with nausea, vomiting, edema, ascites, again a liver problem, it seems. Severely deranged LFT were mentioned, and even they said that the patient is suffering from hepatocellular carcinoma. So they gave a clinical scenario, they said it's a hepatocellular carcinoma, and they said what could be the pathogenesis. So they mentioned most of the things, and I hope you remember in the classes also, and we discussed that the VAT mnemonic we gave, and then we talked about an aflatoxin, like VAT is for angiosarcoma, and then we discussed about the aflatoxin, which is seen with hepatocellular carcinoma. So, because it's a hepatocellular carcinoma they are talking about, so obviously it's going to be aflatoxin. Then child presents with hematuria. Now this was again a question in which people gave a lot of history, different kind, and we were not able to come to a common conclusion, but what they can conclude was 20 RBCs per high power field was given, and there were RBC casts were also mentioned. Some said proteinuria was also there, edema was also there. ठीक है, होगा, सब हो सकता है, but because hematuria is so much, and they said dysmorphic RBCs. Yeah, somebody added dysmorphic RBCs also to it. So, because you are saying that dysmorphic RBCs were there and so gross hematuria was seen. So, it has to be a case of nephritic syndrome, because it's a child who is having a nephritic syndrome. So, it cannot be anything else than PSGN. IgA nephropathy more commonly seen in adults. Okay, so PSGN would be the answer for this. Then history of, again a PSGN question, history of PSGN was there, throat infection was there, and they're asking about a causative organism. So when we are talking about PSGN, in our workbooks, we know that what is PSGN, when type 3 hypersensitivity, where there's a molecular mimicry or cross-reactivity of the antibody which has formed against the antigen of whom? Group A beta hemolytic streptococci, which goes and can damage our heart, our kidney, and even the joints. So we have discussed this in the classes. So again, this is group A beta hemolytic streptococci. What are the other options you can give me? Then patient presented with hypertension, palpitation, sweating. So this is a triad which I told you with pheochromocytoma, that it's a triad which is there, HSP we wrote, and but then they were taking you to pheochromocytoma, but suddenly they wrote one more thing, and that was aldosterone was very high, and the patient was having hypokalemia. So whenever aldosterone is very high, it is hyperaldosteronism. And hyperaldosteronism, out of the 4 given, like pheochromocytoma, तो aldosterone से कोई लेना देना नहीं है. तो अगर ये pheochromocytoma it would have been, so aldosterone levels high नहीं होने चाहिए थे. Aldosterone levels are high, तो मतलब it is hyperaldosteronism. Now hyperaldosteronism can be primary, secondary, and primary is due to hyperplasia, and secondary, primary has hyperplasia and the cancer. So hyperplasia is more commonly associated with high aldosterone levels, but then because here primary hyperaldosteronism में hyperplasia of the adrenal gland was नहीं दिया हुआ था, so what is the answer with this? With this it would be Conn syndrome. Conn syndrome क्या होता है बेटा? Tumor. ठीक है? So it's a tumor which is arising from the zona glomerulosa, but that is it. So ये answer ना बेटा इसमें pheochromocytoma बच्चों ने mark किया है, but then because I have been told that aldosterone levels were given, so then, and they were very high, they were elevated. So the Conn syndrome would be the answer for this question. Then clinical case typically showing pheochromocytoma, वो पूरा history दिया हुआ था, headache, palpitation, sweating, hypertension भी थी, and treatment for the same. So when we were talking about pheochromocytoma, I told you that pheochromocytoma में होता क्या है बेटा? Epinephrine and norepinephrine, they are high. Now they increases the sympathetic activity. So because of them, there will be activation of alpha and beta receptors. So alpha receptors would do vasoconstriction, and beta receptor will do increase in the heart rate and BP. So the point is that when you treat these patients, See, if it's a tumor, you have to remove it eventually. Pheochromocytoma को आप remove करोगे. So, but you do not take the patient directly on the surgery table. You give first the alpha blockers, then you give the beta blockers, and then you move on to the surgery. So, what is the answer for this question? Alpha. We have done this in the chapter of endocrine with the topic of pheochromocytoma. Then, which of the following is responsible for delayed healing? So this is, when we were talking about scar formation, the chapter of inflammation, we discussed a step called as remodeling. And for remodeling, we have an enzyme, matrix metalloproteinase. And in that, I told you zinc is important. So, if you do not have zinc, the enzyme won't function. You'll not have remodeling. Obviously, it will cause delayed healing. So the answer is zinc. These were the options I've been told that they were given like that. Question was a little different. I mean, it was not a single liner. There were 2-3 lines, but this is what they had asked. And this question is something, people are not able to tell me the disease name, that what was the name of the acute disease they mentioned, but they said that, it was a 5-6 line case. They mentioned the disease at the end and they asked that which antibody would be present in this. So if it's an acute case they have given, and they're asking about the antibody, then whatever be the clinical case it was, if they're asking about the antibody for an acute thing, it's going to be IgM. Okay, so these were the questions which I could gather from the students. And, again, I'm repeating myself, guys, that it is not the exact replica of what questions came in the exam, because that can't be done. So we know that there were long questions, but with this recall, what I wanted to do was I wanted to give you an idea about what exactly came. And this paper told us one thing very clearly, that, learning the questions doesn't help. Even doing the single liners doesn't help. It is about understanding the concept. So people, you people have been real warriors and you have studied that way, that you could understand a concept, and that is why even in these kind of questions you were able to pick out the right words and you were able to tell the essence that, okay, this was there, this was there, this was there. That is why we marked this. So this can only happen when you read conceptually. So I hope you do good, and when the result comes, it gives us the happiness that the last time also we were very worried, but when the result came, it gave us a lot of happiness. And I hope that each one of you passed this exam, and we all then would celebrate. Good luck to all of you for your result from the entire team. Thank you very much. Bye-bye.